So, Tufan, I often hear that our guidelines tell us patients don't need to undergo any sophisticated diagnostics before undergoing interventions for stress incontinence treatments. And I believe it's a little bit of a misunderstanding of what our guidelines actually say. So when we talk about the American Urological Association guidelines for surgical treatment of stress incontinence, it is nuanced. There are three different levels of how each statement gives recommendations: a must, a should, and a may. And so you can see there's different types of implications for the provider. So what's actually said in our guidelines is that clinicians should perform additional evaluation in patients being considered for surgical intervention if they have a myriad of conditions, like the inability to make a definitive diagnosis, the inability to demonstrate directly stress incontinence on your physical exam, which can happen for a whole variety of reasons, any known or even suspected neurogenic lower urinary tract dysfunction, if they have an abnormal urinalysis or some other unexplained issue, if they have mixed incontinence, if they have an elevated post-void residual, and that's per my discretion if I feel that that's elevated, if they have pelvic organ prolapse, and if they have any evidence of voiding dysfunction. You may perform these procedures too if there's overactive bladder symptoms, or if they've had failed prior procedures, or if they're going to be undergoing a prolapse surgery. So the guidelines panel understands that we should be doing these procedures in most of the patients that we see. And for those that it is at question, that we may do them. So it's given us great latitude. It is actually an extraordinarily rare patient that doesn't need some type of diagnostic outside of the very basics for undergoing an invasive procedure. And even in that situation, our guidelines actually say that even though you should not routinely perform cystoscopy in the index patient, that you may omit urodynamics. Now, those are two different statements. That you should not perform cystoscopy unless there's a concern for some type of urinary tract abnormality, but that you may omit urodynamics, and that you may perform them for all non-index patients. So those are completely different messaging. It is not that you should not perform these procedures, but that you may omit them. So it is more of okay, this is the patient where I may not need that information to move forward, but the baseline strategy should always be in a stress incontinence patient to obtain all that information because it's going to help you in future diagnostics and counseling.
Yeah. Well, I think the guideline panels are doing a great job by presenting us the available evidence. So we have to understand correctly what we should expect from a guideline. The guidelines do not tell us exactly what we have to do in a particular patient. They give us recommendations basically about the clinical symptoms or syndromes, such as overactive bladder syndrome or stress urinary incontinence syndrome. However, they do not tell us, and they do not have to tell us actually what we have to do on a particular patient. And this is especially true for diagnostic methods, as you said. So looking for evidence for every diagnostic method is challenging. This is really difficult. If you think, for example, urine analysis, how much evidence do we have that we have to perform urine analysis for our patients? But I think everybody agrees that urine analysis must be performed as a basic evaluation method. So diagnostic methods, recommendations on diagnostic methods are really here challenging. You have very well summarized what the AUA guidelines basically say. This is more or less the same for the European urology guidelines, where they have two levels of recommendations as strong and weak. And the EAU guidelines indicate that urodynamic studies are warranted, invasive urodynamic studies in patients with complicated stress urinary incontinence, as we have been discussing in this dialogue. And also for the uncomplicated patient group, they say that there is no robust evidence that urodynamics improve the outcome of treatment here. Again, so we have to be careful about how to evaluate or understand the guidelines and understand what they are basically saying to us. Again, the guidelines do not tell us what we have to do on a particular patient, and they do not give recommendations here, especially regarding stress urinary incontinence and overactive bladder syndrome, regarding the precise pathophysiologies, but they give recommendations on the syndromes here in the guidelines. So, but still, I think they are very helpful in presenting us the evidence so far in the treatment and evaluation of these patient groups.
Yeah, I agree. And moreover, as we've kind of touched on already, the value to the patient, because I can then communicate with them much more adeptly regarding what the potential outcomes are going to be of any type of procedure that we're going to undergo based on this functional study. I can tell patients with voiding dysfunction what they may expect, and with some degree at what frequency these issues may occur based on my urodynamics. So it gives the patient, again, an ease of understanding the information of their condition and of the outcomes that they should experience. We always want our patient expectations to match their outcomes. But when you're talking about complicated patients, sometimes unfavorable outcomes can occur. And the patient that's counseled about those potential situations beforehand always comes through that situation with a much more understanding outlook, as well as a more successful long-term resolution.
Exactly. Maybe this will be a local comment, but if an unfortunate medical legal issue occurs after a complication, I don't know how it works in different parts of the world, but in my country, if there is no urodynamic study prior to a surgery to treat a complicated urinary incontinence, then this will be considered as a mistake or malpractice of the physician. This may be different in different parts of the world. I don't know how the situation exactly is in the United States, Melissa, but it's very clear in my country, a very clear malpractice. If you do a surgery and face a complication, and if you are sued after a complication, then the court will look for a urodynamic study prior to your surgery.
So we also live in a very litigious environment, especially with what's occurred with regards to the utilization of mesh in the transvaginal space. And many times those types of studies, having that information is very supportive of the physician's plan of action. And so I think that that is always a great adjunct to very careful medical records of having objective data. And also, again, if the patient understands that there are potential complications that can come with these surgeries, that you have spent an enormous amount of effort and time undergoing that type of counseling with a patient, and it's backed up by what is a minimally invasive procedure in order to get diagnostic information to drive decisions, there is very little with regards to litigation that would outside of something that most of the listeners of that are undergoing a call like this would have experienced, there's very little that actually would merit any type of malpractice. You have done your due diligence, and even in the best of circumstances, with all the information available, outcomes don't always meet our expectations with regards to optimization for the patient. And that's just an unfortunate situation in medicine, as in art, and in every different patient physiology that we encounter. But I would agree, we both live in very litigious environments in which the more data, the more information you have available will only help give the patient some degree of satisfaction that appropriate decisions were made on their behalf by their care team.